County Councillor David Wesley, Chairman of the committee. And we have County Councillor Carol Haythorne-Waite. And next to me is Gary Halsall, Senior Democratic Services Officer. Just on a little bit of housekeeping, there's no fire drill planned for this morning. However, if there is a continuous alarm, we're to meet in the Arthur Street car park, Assembly Point C. Don't hesitate to gather personal belongings and do not use the lifts. Wait at the assembly point in the car park until the all clear is given to return to the building. The committee is being webcast. Please press the button on your microphone if you wish to speak, and to switch it off afterwards. Mobile phones should be switched off. And we have some people joining us on Teams, including, is it one member of the committee? Two members of the committee. Welcome. And please use, if you're using Teams or joining us on Teams, please use the raise the hand if you wish to speak when we're discussing an item. I'd like to welcome any viewers watching on the webcast. And we have present with us today Dr. David Fernley, Chief Medical Officer, and Chris Oliver, Chief Operating Officer from the NHS. We've had apologies from Charlotte Hammond, the head of the county's learning disabilities, autism and mental health, and Mark Hindle, Managing Director of Lancashire and South Cumbria Pathology Services, will be joining us later. Item 1, apologies. We have apologies from Councillor Frank Cant, Burnley Borough Council, and Councillor Julie Robinson, Wyre Borough Council. In temporary replacements, we have County Councillor Samara Barnes replacing County Councillor Mohammed Iqbal, and Councillor David Borrow is replacing Councillor Jennifer Mean from Preston City Council. Yes, dear, Councillor Borrow. Oh, David Nelson, was it? I never met him, but I heard of him. You must, yes. Well, I aim to stick fairly closely to a 2-hour time. We should get through the two main items on that. Item 2 is the Constitution. Already introduced myself and Councillor Haythorne-Waite. We were appointed by the County Council, full council. The second part of that is the membership of the committee, and the third is the terms of reference to the committee. And we'll just have to note that. Item 3 is the disclosure of pecuniary and non-pecuniary interests. Thank you. Anybody else? No? We'll note those. Item 4. It's the minutes of the meeting held on the 23rd of March 2021. Have we got anybody present who can seconder? Councillor Collins? Those agreed. Item 5, which is on to the main business. mental health integrated community care transformation. And you're going to present that to us. Welcome.
Oh, sorry. Sorry, is that working? Sorry about that. So the ambition is very much to move to the central, that the person is center at everything we do around this. So it's to, as I've talked, it's to meet the needs of those with severe mental illness. It's very much based around primary care, social care, and the voluntary sector and faith enterprise, which in historic times within mental health, I think has been quite an underdevelopment. So it's really good to see this coming together. You can see under section 3 in the paper, we talk about the 3 levels of community. So there's personal community, neighborhood community, and locality community. And this mental health transformation is very much based around that neighborhood community element there. And you can see the various networks within that. So primary care networks will be a select group of GPs working within their community and the needs around that community. So that the MDT that the service user will integrate with are listed there. So you can see that it's be mental health practitioners, social care, voluntary sector, primary care, substance misuse, but also peer support workers and housing, finance and employment support. So that whole holistic approach around the person. If I take you just forward onto section 4 in the paper, you can see this talks about the Trust's initial response service. So this sits outside of the investment of 12 million and is additional investment going into mental health services. By April 2020, each of our we've got 5 networks within the organisation. 4 are based around geographical footprints, and each footprint will have an initial response service in by April next year. This is very much a one number for any mental health concerns. It will be staffed 24/7 by call handlers. There will be clinical triage at that point, and then they will be signposted into either advice, guidance, transferring to mental health services, or if urgent required, then that would be face-to-face, either in the individual's home or within a mental health setting. Section 5 of the paper just describes the leadership and governance that we've got set up around this, and you can see that the Community Mental Health Transformation Steering Group at that top right of that diagram, and that is co-chaired between mental health and the voluntary sector. Each of the localities, and you can see them down on the second to bottom line, these partnership delivery groups, these are the integral. So this is where the national model, the national framework is being nuanced down at local level and very much at that PCN. So what is right for that population within central might be completely different to the Bay and the nuances that local services and local people require. So as I talked about engagement, so we've been 2 months into this project. There's been a range of stakeholder events already taking place with a wide range of people that have participated and helped shape the model to date. And you can see there on the timeline where we're up to at the moment. So we're currently out to some of the recruitment to some of these posts. And in the initial summary paper, that is one of the risks, is around the ability to recruit at pace, at the scale of recruitment that's within this paper. And there's a separate workforce and recruitment group specifically looking at that. So that's probably the paper, the highlights within the paper as a summary. I'll hand over to Dr. Fernley if there's anything further to add about the model itself, but I'm happy to take any questions after that.
Thank you very much. So it's a real privilege to be able to come and talk about our work here. We've been designing this with colleagues from the local authority and across all sectors. It sets out, it's in line with national best evidence, but we were able to design it so that it fits in as well as we can with our population. And we're drawing on best practice from outstanding NHS trusts across the country. So it's a very strong model. We think it's the right thing for people, looking at incidents, looking at complaints, looking at where care hasn't gone in the way we want it to. We think this is addressing some significant unmet need in our communities. So we're very keen as a provider to work in collaboration, work in partnership to make this work for our population. It's a very complex endeavour. It's happened, the design has taken place during the pandemic, but we've learned a lot in that time about how to support communities and those that most in need. So I'll be very happy to try and answer some questions about the clinical model or take any other questions. So thank you.
Well, thank you both for that. Councillor Collins, you have a question.
Thank you. So my first question is this deliverable? Within the resources you have, and I note the risk around workforce, is this actually deliverable? I'm thinking back to a few years ago when we were told about inpatient care, where we'd have assessment chairs in Blackpool and they would only ever be used for 12 hours. And we know that that's not the case. We know that they're used in other ways, and that the inpatient system is really struggling. My second question is, what sort of service user engagement has happened? So what sort of lived experience? Has it been deep? And my third question is, what will the rollout look like? Will it go live, BAM, across the whole of Lancashire and South Cumbria, or will there be pilot areas? Thank you. Thanks, Chair.
Hello. Right, so, yeah, okay, thank you for your question. So is this deliverable? Absolutely, yes. So it's not without its risk around workforce, but this is a tried and tested model. The framework's national, it's been done elsewhere. So some of our sites within Cheshire and Merseyside are currently running with this model. I think, you talked there about inpatients. So that this is only part, I suppose, of the whole transformation within mental health services within Lancashire and South Cumbria. So there is significant expansion and redesign within inpatient care. And then this dovetails in at that community level alongside the initial response service. So I think had this been coming in without the transformation in the other parts, it would be more of a risk, I suppose. What we're doing is transforming the whole patient pathway, if you like, and this therefore dovetails into that transformation.
Thank you. I mean, you did mention about the assessment chairs from a few years ago, and I was talking to a colleague in the northeast where they've piloted they've rolled out the initial response service, and they've had a big impact on the work. It's helping to keep people in the community, doing unnecessary admission to hospital for assessment. So it's a model we're confident has been demonstrated, but clearly we have to adapt it so that it fits in with our population. There hasn't been, I think, sufficient service user care engagement, because I never think there is. We've tried very hard during the pandemic, conscious that people were isolating, conscious that it was difficult to get meetings together, but we have had very big engagement events, which has involved people, invited people. But I think we're at the stage where this, if not that the model can't be developed, this is where it starts to get real for people. So very passionate about having co-design and service user engagement. We're planning to do more of it. And I think that's the only way this will work. But yeah, I'm conscious that there's never enough engagement to ensure that these services are bespoke and designed, but it's certainly something we think is a priority, and the way this will be successful. It will be rolled out incrementally. We did a risk assessment at the start of the year, looking at the new primary care network, a key to connection. And at that stage, primary care networks were still pretty new. There hadn't been appointments as clinical leads across all of them. So we worked with the primary care networks in our locality to say, how could we get this off the ground first? Where would we get early wins, so to speak, but also to spread it very quickly. So we're conscious that we have to roll this out, aware of the risks, aware of the infrastructure and where localities are. But that was in our mind at the very beginning, that we would overwhelm services, but we'd also target it where we thought it would have the biggest impact.
Councillor Borrow.
I want to follow Liz's. Not be. And which is about to start. Just come around that or we is the committee really got to it. The other thing which did jump out in on page 20 under item 3 at the bottom, mention that a theme on the list to talk about would be the quality of the housing support. One of the things we have seen in Preston over the last 18 months or so is the development of houses in multiple occupation owned by, in some cases, charities, but in some cases, not-for-profit companies, providing very low levels of support, yet charging £250 a week to provide a room when the going rate for housing benefit in Preston is about £70. And there's lots of examples that have emerged in Preston over the last 18 months of vulnerable people being placed in these properties without adequate support. And indeed, I think there was a legal case where the judge said 2 hours a week support was adequate. Concerned that in terms of the NHS is commissioning that housing support, need to get it right, because there are a lot of companies and organisations out there that I certainly would be very wary allowing the client group that we're talking about to be placed with.
Are you happy with those questions? You put them all down?
Yep. I think, we would express the same concern with recruitment, but I suppose maybe with knowing the work that's ongoing currently within the trust. So there's a lot around upskilling of workforce, changing of roles, and using the voluntary sector and peer support workers very much with lived experience and bringing that into play. So I think it's not without its challenges, but I think recruitment's started. We've started the recruitment for the initial response service. We've seen some really good take up of recruitment with that. I think by phasing in the initial response service up to April next year, that gives us a bit of a head start around some of that. The concerns you raise around the housing support, we'll take back and we'll make sure that we link into the work streams around, and there's some really valid points, and we'll make sure that we've explored them further.
Thank you. Yeah, a couple of areas. I have concerns about workforce, in terms of there's a great demand for mental health services, and I'd like to see maybe some information on you've got all these bodies, what are the structures behind it? Some information going along as to how you fill in those structures. Some doubts that position with other providers, you may struggle. The other issue is about communication of this whole system to the general public. You know, there's a lot of people out there, particularly with the pandemic, on their own, stuck in single rooms, suicidal thoughts, might need immediate help. How do they get it? How is this publicised to the general public?
Around the communication, I'll come to the last question first, if I may. So very much led by NHS England and NHS Improvement around their communication strategy for example, the mental health crisis line. So we've now got a crisis line within South Cumbria that is staffed 24/7, and we continue to promote that within social media and in other means within community. I think this next step and the initial response service and the whole transformation, we can never do enough to promote the services. That sits alongside here is that whole communication and engagement strategy to make sure that we are reaching out to everybody, so that everybody knows the one number that you would need if you're in mental health crisis or you need. Sorry, did you?
Just, I suppose, as the first question about staffing and resource, and something we have learned a lot about, and we're not just ourselves, is the digital opportunity that's changed the way we're delivering some services. It's not to say we substitute good in-person care for the computer, but what we are finding from speaking to people is that some of this is very acceptable to people, different parts of our demographic, that having online consultation means that we can think differently about our services, that whilst we need people, we've also got other ways of communicating that to some people they prefer. So we're working through that. We have an online consultation project board in the organisation where we're looking at the evidence that's been gathered in the pandemic. What would people want, and what gaps are there that we could say actually some of this could be done differently, done remotely. Some of the consultation advice can be done in a different way, not to underestimate the need for face-to-face consultation when it's needed. So we're working through that as well, because I think that's a practical consideration for us. If we want to get a workforce, how far afield are we attracting people? Are people working remotely, and how do we build that into a safe model for our service? And this gives us the opportunity to do that, I think.
And just follow that up, Chair. Just interested, how do you measure your success? I mean, do you look at, right, how many people are coming through A&E that can't access any of these services? How do you actually liaise with others to find out where the gaps are?
Well, we survey, we ask people questions, we ask for patient experience, service user experience, so we ask directly. We take part in wider consultation, and we've worked with HealthWatch on some of our other models, so we get other feedback. We're building measures of success, so what we want to demonstrate in this is evidence that we're improving, looking at how many people go to the emergency department, how many people should have gone somewhere else, could have gone somewhere else. So we want to look at every part of the pathway to see, can we change people's experience? What this is trying to do is, I think, largely avoid an unnecessary stay in hospital, because care can be provided in the community. It doesn't have to be provided by a mental health provider, but we have to build in those measures, otherwise we won't see any change. But I think it's always an issue for me, how do people who are disconnected, disenfranchised, isolated, how are they getting the care they need? So we think this is a more diverse model with more partners to try and help those people that otherwise may fall down between our services. So we're building measures into this, and I think that's part of the way we'll demonstrate to people that it's working. It's a change, it is a transformation, so that we are doing things differently, so we'll have to find ways of measuring that differently.
Yeah, I've got Councillor Oakes and then Councillor Dowding.
Thank you, Chair. Just to ask, you mentioned about the involvement of volunteers, and I'm just curious as to where they would be involved and how much training you're giving them and how much reliance there will be on volunteers.
Thank you. So it's an explicit ambition to have far more involvement of the voluntary sector. And so Peter Armour, who's part of the Integrated Care System Board, is being really helpful in connecting with the voluntary community and co-chairs the group that is overseeing all of this deliberately to understand how do we ensure we've got representation across all the different voluntary agencies? How do we encourage people to take part? What are the skills? What skills do people bring? And that's going to be part of the design. I think it's worked elsewhere. We've also got very good examples of the voluntary sector here working with our services, but this will be new opportunities. But I think the involvement through Peter and the wider network is our way of getting that engagement, getting people's thoughts, getting people's ideas about how they want to design this. So it's still in that stage of bringing people in, trying to work through, seeing whether it's telephone line, whether it's brief counselling, what are the skills people want? Is it to help with day-to-day activities? Where could we work with the strengths of the voluntary sector to make this work? It's our ambition, but by working together, we think we can do that. At the moment, I don't think the work maybe is as close together as it should.
Councillor Dowling.
Thank you, Chair. Thank you for the presentation and the moves forward on this. So my 3 questions actually follow up from things that other people have said. In terms of the issue of recruitment, as a committee, the Health Scrutiny Committee has heard for years and years about the difficulties in recruiting to NHS trusts across the gamut, the whole range. So, you know, this is a long-standing issue, but there's no mention in here, and about attracting new recruits into this sector and actually training, working with our colleges, or if there is, I've missed it. And I realise that that's not something that would fill a gap that's required in 6 months. But given that we know that this is an endemic long-term problem, is this something that you are using some of these resources to actually look long-term about training opportunities and making the sector more attractive to people or our homegrown potential workers in Lancashire? I also was going to ask about, you know, how do you measure success? Because I noticed that one of the measures you mention here is about the waiting time, or sort of like people getting the right treatment within 4 weeks. But obviously, it's stopping that revolving door, presumably, and getting people stabilised is a key measure. But I'm assuming that there's a whole different conversation to be had or presentation about your success, you know, your indicators. And so just any more information you have on that. But my third question arose from the question about use of volunteers. And I think obviously it's really important that we understand that the voluntary sector doesn't necessarily always mean the use of volunteers. It's about using different types of organisations that are more nimble and could be flexible, which is great, and sometimes volunteers. But one of the disadvantages, there are many advantages, is that it's quite disparate across the county in different areas, so that you might have excellent provision in a certain area of Lancashire that isn't matched in others. And are you going to be helping, or is that funding available to help develop the voluntary sector so that they can emulate good practice and build up their sort of capacity?
Thank you. So on the matter of recruitment, absolutely we are doing an awful lot of work, as you would expect, for recruitment. So we are, I suppose, an NHS provider that covers the whole of the ICS as the main mental health provider. We've got a talent management, a recruitment, and an attraction piece. So it's about making what makes working for LSCFT attractive as an organisation. We're doing lots of work around our culture. Already started to see some real improvements within our national staff survey. And on the back of that, we are linking in with colleges, very much so, around our nurse trainees coming through, about the step up programs. So for individuals that would be traditionally the unregistered cohort of healthcare assistants, and how we would then train them up through the qualifications to become registered nurses. And we've also got a piece of work which has mainly been done in the acute sector for quite a few number of years around overseas recruitment, and we are leading that within the North West for Mental Health Trust. On the measurements of success, so there's already a wide range of metrics that Mental Health Trust can be measured against, of which and we would expect to see, as David's talked about, some of the evidence base, especially within when they implemented their initial response service, saw some real swing changes in for outcomes, and we would expect to be seeing them, and that's what we would expect to see within our trajectories for improvement. On the voluntary sector, I think this model gives us a real longer term basis to commission voluntary sectors so that they are able to be more nimble, but also to recruit on a more substantive basis than previously maybe they've been able to do. I think that working with Peter Armour and the consortium, that helps with that disparate and the services that are provided across the whole county, and trying to what works well elsewhere, what can we learn from them. There are others examples of that within the early implementer site with the sector. What they found as organisations has worked well, and we're bringing that back into the conversations with Peter and colleagues around that.
Thank you, Chair. My questions relate to the shared practice model, in particular around the thoughts around the ambitions around being trauma-informed. It's really around how do we make sure that the partners, in particular the voluntary community and faith sector, are working using that trauma-informed model. What's the training like? How will it be monitored? With trauma-informed practice, it's about modelling the model and not just doing training. So how will you make sure that maybe a working group in Rosendale are working in a trauma-informed way? And shouldn't the ambition to actually be trauma responsive and not just trauma informed?
Thank you. I think it's an excellent point. I saw the insights around what was known as trauma-informed care some years ago, and I thought it was revolutionary. It really did shift the way people thought about people's experiences. I think by making it explicit, I think made the first but big step to say we expect to see this in the model. It will definitely develop, and we have people I know in our own organisation, other organisations who really do understand this field. They understand the theory, they can understand the practice, and we'll be drawing on that, which we do already in some of the services, to ensure that we grow this approach. So I was keen that it was part of it, but I don't think it stops here. I think we have to sort of work with this and develop it so that we can really get insights into why people are experiencing the life they do and how we can think differently about preventing but also helping people. So I take on board the point. It's a model we have to develop. We will be maintaining that standard and looking for it in the model.
Can I just add one last very quick question? If there is a reliance as well on peer mentoring and peer-led approach, how do we really support those people who are spending a lot of emotional labour and are still suffering that trauma to work in a trauma-informed way? It's just really, my thoughts are around looking after those people who are going to be responsible for looking after people in our communities.
I agree, and I think it's important when we ask people to engage that we're able to support people in that process, because as you say, it can be stressful, it can be a number of reasons why it can be a problem. I think many people find it very beneficial, but we have to be able to support people when they get involved because of those issues. So we're aware of that, and it's something we will continue to be aware of and mindful of, and I think it's the right thing for us to be thinking about.
Well, thank you for the presentation and answering the questions. Have you got what?
Follow up on one.
Okay,
I just
Councillor
wanted to
Pope.
check. You talked about 12 million. Is that over the 3 years? So it's 4 million a year. Okay. And just another question in terms of recruitment and training and whatever. Have you areas with the university again?
Yeah, I think that's universities and our training. Yesterday we were big into working with universities to
So they're ensuring that their students are involved in placements.
Yeah.
Understand this. And the same for their Jill. Lancaster. Yeah.
Right, so we'll move to the next stage now. You can stay and listen to us after any urgent questions. We look at the recommendations. We have down here to note progress and next steps. The second one is to provide support to help deliver the ambitions of the programme. On the first one, note progress, I think we have done. And the next steps, can I just say, it's an ambitious programme and bringing together a lot of organisations. I think we'll all agree it's needed and welcomed. Take a great interest in it. It's perhaps would it be possible for an update in say at launch time?
absolutely be delighted to come and take on board the questioning.
We can fit that in, or perhaps even just a written one. See, and we'll have talk about that. Yeah, we're very busy. There's a lot going on in the NHS at the moment. A lot of reorganisation, and a lot of things to look at. But yes, the offer of that. Any members of the committee want to express a view on the first point that's here?
I'd just like to see some clear success measures. How do we, in 12 months' time, 18, 2 years, whatever, how can we as a scrutiny committee see the success or otherwise?
If I may come in there, I think at the moment it's more about making sure everything's set up for it to as planned, and that basically is the next step for spring next year. And after that, we can obviously, if you still want to take an interest in it, which we will do, we can have to, performance effectiveness after that. Are we all happy with that? Some sort of either written report or Councillor Collins?
Oh, I'm sorry. I thought you were moving on entirely. I was just moving on to number 2 around how can we provide support to deliver this?
Sorry, I didn't catch that.
How can we as a committee provide support to this
I was
programme?
coming to that next.
Sorry, Chair. I thought you'd moved on entirely, and I wanted to make sure that was captured. Thank you.
Yes, so that we agreed basically on the first one, and the second one was to provide support. I am conscious that it says here that the engagement of colleagues at the county council has been very good, or exemplar, as it says here. Do we know what the engagement is? Would we like to know? Would we like a briefing on it? Either a written briefing from officers? Is that feasible, Gary? Yes. To come back, perhaps initially to the steering group, but we can pass it on by email even, just to know what we're actually doing. Then we can ascertain whether there's any, anything we need to sort of chivvy up to make sure we are providing the support it mentions in here. Are we happy with that? Councillor Dowding.
Thanks, Chair. I'm a representative of the district councils on this committee now, so I just wondered whether there is also a relevance to district level second-tier authorities in terms of support that's required, because certainly some of the issues raised around housing support, etc., aren't done at the county level. Yeah. So I don't know whether that has any implication for the recommendation, but presumably when this recommendation is talking about our professional staff and how they're engaging with you, and then I'm assuming there is another level where there's professional staff at the district level who also need to be engaged. So if that could somehow be incorporated.
Yes, well, if we get the briefing note from the county first, which will go out to all members of the committee, and we can take it from there.
Fine.
And of
If
course,
that could
Borough-
just be noted, because we may want to hear from how the district councils are also engaging, and whether they, how it's trickled down, or because there's so many of them as well, whether that's working across the piece. Thank you.
I mean, yes, I was going to. Can I just say, we hear so much in the media about the needs, mental health needs, of the nation, and this is a very welcome development, and we must do everything we can to help with it successfully implemented. Do you want to speak? Well,
Yeah,
hang up my
thank you,
glasses.
Chair. I do find it a bit strange that we're having to go back and ask for evidence of how the County Council has been exemplar. One might have hoped that there'd be an appendix to this report if we're being asked to provide support and accept that that is the case. Surely we shouldn't be having to go back and ask for evidence of it.
Just to let the committee know, we did have Charlotte Hammond, who is one of the head of services for learning disabilities, autism and mental health, who was due to attend this morning's meeting to present alongside the NHS representatives. Unfortunately, she's had to give apologies for not being so well today.
So we've reached agreement on that. So that's the end of that item. Thank you both. And we'll move on to item 6 in a moment. Right, we're on to item 6, Lancashire and South Cumbria pathology collaboration update. And we have Councillor Mark Tyndall, Managing Director of the Lancashire and South Cumbria Pathology Services. He's with us on Teams. Welcome, Mark.
I am, Chair. Yes, I am. Is it over to me?
You're on, yes.
Right. Okay. Thank you. I've got a presentation just to illustrate some of the points I want to make. But can I just, before I start, thank you as a committee and a chair for giving me the time to do the presentation today. 2, just put this in the context of what pathology is very briefly. Pathology is about the diagnosis and recommendations for treatment of disease. So that could range from things like diabetes, and people with urinary tract infections, through to COVID-19, through to very complex cancers, and other quite complicated diagnoses for people. So that's what we broadly do. The vast majority of work that we do in pathology is routine, but as you can appreciate from what I've just said, some is very complex and some is absolutely, well, all of it, I would say, is very pertinent to the patient journey through a hospital, or from a GP to a hospital back into community, or preferably keeping people well in their own home through primary care. What's been proposed is about bringing pathology services together across Lancashire and South Cumbria. And I make that point briefly before I go into my presentation, because this is not a patient-facing service. This is about doing diagnoses on bits of patients, be they tissue samples, be they blood samples, whatever they might be. So because it's not patient-facing, it's not subject to public consultation as a consequence of significant change. But I think it's really important that we have a conversation with all the key stakeholders, of which the Overview Scrutiny Committee at Lancashire County Council is clearly really important, and make sure people are aware of what's being proposed and have the ability to comment on what we're doing. So with that as an introduction, I'll just pull up my my slides. Just bear with me a second. Can I also apologise for not being there in person today? I was at a funeral in Worcester yesterday, and I did realise I couldn't get back without setting off at some ridiculous time this morning. So I very helpfully have allowed me to join by Teams. So can somebody just say they can see my first slide, and then I'll carry on. On the basis that I've not got any negative feedback, I'm going to go through about 5 or 6 slides that that describe what we're trying to achieve. So my second slide is about what is this about. So this is a collaboration of the 4 large hospitals within Lancashire and South Cumbria about bringing our pathology services together for provision for the acute care, i.e. the hospital care, and primary care. The testing we do splits roughly 50-50 in terms of 50% we do for GP colleagues in the community, and 50% is for the acute hospitals. I'll keep us going. I'm sure colleagues will have questions at the end. So why do we need to change? Well, I've just listened to the end of the previous conversation about mental health. There's various reasons for change, and they are listed there in 1, 2, 3, 6 bullet points. One, there is a national policy about transformation with the expectation that organisations will work together in sensible geographies. And for pathology, we have been grouped together on the footprint of Lancashire and South Cumbria. So the patch, I know colleagues will know what that means, but my patch runs from Barrow right the way in the north through all the hospital footprints in Lancashire. So we cover the whole of Lancashire and the South Cumbria patch up to Barrow. We have significant issues like many parts of the NHS in terms of workforce, not only in terms of recruitment, but also in terms of an ageing workforce. I think something like 40% of our workforce is over 45, with a third over 50. So there's nothing wrong with being over 50. I'm over 50, but what it does signal is over the next decade or so, we are likely to lose significant amount of our trained and experienced workforce, and we have to do something about that before it becomes an unmanageable problem. I won't go through all the rest of the things in there, other than just point you towards bullet point 3, and that's resilience to the current service. There's a general perception out there that hospital services are quite resilient. Well, in pathology, I would say that is not always the case. Some of our estate is very poor standard. Some of our automation, which we heavily rely on, is relatively aging and needs replacing. And our IT system, which is the backbone of how we analyse things and how we report things, is very variable. It ranges from a new, modern, state-of-the-art system in central Lancashire to a system in Blackpool that will not be supported by its current suppliers past the end of next year. So there is a real need to come together, improve our infrastructure, and ensure that we can provide resilient, reliable services into the future. So what are we proposing to do? So what we're proposing to do has gone through a clinically led and very thorough involvement process of looking at how we establish ourselves and how we organise ourselves to deliver pathology into the future. So I've already flagged up there are significant issues that we'd have to deal with urgently in the current service in the current hospitals, or we completely transform what we do and provide our service in a very different manner. So the plan that we've settled on, or we are putting forward, is one of a hub and spoke model. So the majority of what we do is routine. I would estimate about 70% of the testing across the board is routine. So we plan to organise ourselves in a hub and spoke model where all the routine work or work that doesn't require an immediate result will be done together. And that means we'll be able to concentrate all our workforce, so we're much more resilient, and we'll be able to upgrade all our automation so that we will have the state-of-the-art automation in one place doing the majority of the tests. Clearly, we cannot provide all our services in a central hub for Lancashire and South Cumbria, and even that presents issues with the geography that I've talked about. So all of the very urgent tests, so for example, if you present to A&E and you're bleeding profusely from, say, a road traffic accident, that patient could not wait while a sample is sent to an off-site hub where a cross-match is undertaken and blood is issued. So all very urgent services will be maintained on the current hospital sites, and patients who need access to very urgent tests will be able to have them on site, undertaken within a smaller pathology laboratory. It's really important to note from my perspective, but also from GP colleagues' perspective, that patients and service users, particularly GPs and hospital doctors, should not experience any change to what they currently get. So if you expect to get a result within, I don't know, 2 or 3 days as a GP, you should still get that same service. If you expect to get that result in a day, then you should still get that same service. We are reorganising and transforming to be more efficient, more effective, and provide a better quality service at a more sustainable cost. And two of the key things that will enable us to do that will be re-providing our IT system, so everywhere in Lancashire and South Cumbria has the same system, and all our automation is the same, so that we remove variation, which we currently see from hospital to hospital. I won't go through those. You've got this presentation there. I've just listed in this slide the benefits of coming together as one service under one strategic and clinical leadership and under one automation, digital pathway and IT system. I'll talk about this more in future slides to demonstrate what this actually means in reality. But for now, I'll go on to what have we achieved. So what have we achieved up to now is largely about doing, I won't say the paperwork, that'd be too weak a way of putting it, but it's been about agreeing the clinical model, working through the outline business case and the strategic case, because of what I've not mentioned up to now, is we have been allocated £31.5 million of treasury capital to improve our service. This is a once in a lifetime opportunity for pathology, and we spent quite a bit of time thinking about what's the best clinical model, how do we use the capital, and how do we deliver a more efficient and higher quality service as a consequence of that. There are key things that are really important on that journey, such as looking at workforce models, governance arrangements, how we organise ourselves, because this is very different now from each hospital organisation owning its own service to a service coming together and being supplied back to the hospitals and back to the GP. We spent a lot of time looking at our laboratory IT system, and that's out to tender now. And we're just about to go out to tender for our blood sciences equipment. So we're making actual progress now in terms of things that will make a difference for patients, improving quality and improving efficiency. We've also agreed where the hub will be located, and that will be on the Enterprise Zone Park, which is just off the A59 in Salisbury, which is in South Ribble. We've identified how we're going to build the building, and we are looking to decide very soon which of the current 4 acute hospitals will host the service as it moves forward. The plan is to move all the staff and everything that goes with the service into one organisation, which will then allow us to transform the service much more effectively. This is a picture of what it is a picture. It probably won't look like this when we're finished, but it's probably quite indicative of what a new service will look like and gives you a kind of view of the size of the service that we're looking at. There'll be about 800 staff employed in the new service, and the hub will be, as I've said, located on the Lancashire Enterprise site. We're still working all this through now at the moment with the architects, so it's very much at the beginning of the journey. So I'm having a conversation with you before things have been done, and while we've made some decisions in principle so we can move forward, no actual real decisions have been made. There's not a hole in the ground or a brick been laid yet. So this is the very beginning of the journey. So why a hub and spoke model? As you can appreciate, there are as many people saying that doesn't make sense. I don't like change. What we're currently doing is working okay. Well, what I've said already, what we're currently doing isn't working okay and isn't fit for purpose for the future. A key analysis that we've done in terms of looking for the future is looking at the finances of how we organise ourselves. And when you do the really detailed analysis of a hub and spoke model through a comprehensive investment appraisal model, what it demonstrates is for every pound that we spend on developing a new service, so the £31.5 million I've talked about, we get a return over the lifetime of the service of £8.32. I think that's a compelling analysis that says we either avoid spending money on the current existing tired estate, or we will be more efficient in terms of delivering our new service, and it adds up to £8.32 for every £1 spent. So for that £30 million, we will get 8.32 times the return on that investment. I think that's an overwhelming reason, if for no other reason, and there are significant quality and resilience benefits as well, that we move towards this new model. I would say that the outline business case has been approved by all the 4 trust organisations, and I probably would recommend we look at it. If this was a business, we would look at it as the acute trusts are the shareholders, and the ICS as the representation of GPs is probably another shareholder. And every organisation has endorsed the business case and endorsed the plan to move forward. One important thing to say, sorry, did somebody say something?
No, I don't think so.
Oh, I've only got another minute or two, so just bear with me, please. So a bit about the hub and spoke model. This is a major change for pathology. I've said it should not be seen as a major change for our service users, and we will be very flexible. So, for example, up in the very far north, we'll probably do much more routine work up in Barrow to avoid samples being transported for a long period of time than we do in other places. So the key message to take from this slide is we're working very closely with our clinicians and scientists to produce a flexible approach to how we deliver the service in the future. And my last slide is one that I'll leave up for a minute or two. And this just talks about our key milestones. I suppose without going through them all, the next key one for the pathology service will be bringing all the staff and all the budgets together by the end of this calendar year. No, sorry, by the end of the financial year. And we plan to open the new hub and the new service physically by autumn 2023. So I will finish there, Chair, Committee. I'll close my presentation down and pick up any questions that any colleagues might want to ask me.
Thank you, Mr. Henry. What we'll do now is ask questions and the various questions of our discussion be on the way forward. Have Councillor Pope indicated you wanted to ask a question?
Yeah, I was just wondering, clearly this is going to move costs from the acute services. Who actually manages these costs? And if you find you haven't got enough resource in terms of the ongoing service, who actually provides that? Do you go back to the individual trusts?
So we can't hear you, Mark. You got your microphone on?
Yeah, sorry, I don't know why my microphone went off. Apologise for that, Chair. So that's a really good question, Councillor Pope. Essentially, from next April, all the current budgets that support the running of the 4 current services will transfer into one joined up budget and be under the leadership of the pathology collaboration. So we should have enough money to run the current service as it is now. That will change because if I just use the example of COVID, that has fluctuated massively over the last year, where pathology has, I think, probably had its finest hour and responded magnificently in Lancashire to the challenge of testing patients for COVID. But if we do need more money, and inevitably there will need to be investment, both capital and revenue in the future, the model, which is why I talked about the shareholder model, is probably the best way to think about it. If it was a business, we'd ask for a rights issue from our shareholders, and or we have the opportunity of delivering more efficiencies on the current service. So there's an opportunity to retain the revenue, bid for capital, or bid for capital and revenue from our shareholders if they want new developments or new services. Thank you.
And can I just clarify how many staff do you roughly see remaining at the hospitals?
It probably splits down to, it's probably about 500 staff, 450 to 500 will be in the hub doing the majority of the work, with 200 to 250 stopping in the hospitals, split reasonably equally between each main hospital site and some of the smaller sites as well. For example, Finesse, Burnley, Chorley. So it's not just about the big hospital sites. We provide services on some of the smaller sites as well.
And what consultation have you had with the staff?
So bear in mind, as I talked to earlier on, it's not a consultation model, but I think it's really important that we treat it like a consultation model, because creating followership or staff that believe in the new service and the new model and getting them to come along with you is massively important. So I have talked extensively to staff about the model. It's not I'm not asked them to vote or to actually come together like that, but extensive communication, shared all the documentation as I've gone through today. And for example, now I'm in the middle with my clinical director of having a face-to-face negotiation, is probably the best way of putting it, with some of our consultant cellular pathology colleagues who do the diagnosis for cancer, about how we organise ourselves in the hub and spoke model. So it's not a right of veto, but effectively, if we don't have the buy-in of our workforce, then this is going to be hugely difficult. I'll probably say the next question is probably, have you got buy-in? I think we've got largely, there's a consensus of this is the right thing to do, with a reasonably vocal majority objecting to change. I appreciate this changes people's lives, where they work, who they've gone to work for, relationships with clinical colleagues, and that's quite difficult. But I will say there's a consensus for what we're trying to do, with a reasonable amount of concern about disrupting current work practices and the way people currently work.
Thank you. I've got Councillor Borrow, Collins, Dowding and Pate. So, Councillor Borrow.
Thank you, Chair. Thank you, Mark, for your presentation. Obviously, those of us on the Scrutiny Committee are lay people, and you have mentioned right at the beginning that this is not a consultation model, but often in these sort of situations where we're seeing radical change in the NHS, what we tend to do is listen to the stakeholders and see what their views are and actually test some of the arguments. And I think it's on the page headed progress to date, the fourth bullet point says significant clinical engagement, which you've mentioned, variable clinical agreement. And I think the problem I've got is it would have been much easier for me if there was an assessment, if you like, of are the GPs happy? Is it the consultants that are not happy? Are the unions happy or not happy? where are we with the different stakeholders, and have something explaining what they were not happy with and where they were happy, so that we could have that discussion, because none of that is actually in the report. And I understand you've got, this is, you know, a couple of years before this is due to go and not actually go into operation. But I find it a bit difficult because I'm conscious that I'm not an expert. I don't work in that area, and I do, to a certain extent, rely on the professionals to flag up the arguments. And it's not in your report what the arguments are, and yet we're being asked to endorse the plan. And I've got some difficulty. I mean, I would have been much happier with more information in terms of what the stakeholder views were. Whether you can do that orally and add to what you've already done, or whether there needs to be a more written report in the future to give us that information, which we get a better grip of where the key issues are. If you understand where I'm coming from, because our job is to scrutinise, and this is one of the key tools of scrutiny, is to have arguments put forward that we can test.
Yeah, really good points, Councillor Burrow. I always intended that this was an early part of the journey where I would flag up to the obvious scrutiny committee the plan and what was intended to be done, and take on board comments like that. So we are very much at the beginning of the journey, and it's probably not particularly helpful for me to try and get into the detail of trying to respond to that question today. I would very much like to hear the comments of the committee and perhaps have the opportunity to come back with that analysis as soon as you would invite me back, and I could share that with you. But also perhaps bring some clinical colleagues to the next meeting. If I try to summarise it very briefly, I would say from a GP perspective, there is a level of they don't really care so long as they get the current level of quality of the service that they already get. And what I'm saying to GP colleagues, so that's 50% plus of our work, is you should either see the same service or a better service. And the same to hospital colleagues and hospital doctors, but the promise to them is at least the same service and probably better, more resilient. In terms of people within pathology and people in the unions, of course there are the dissenting voices. I'm not trying to hide that today in any way. This is significant change to the way that a lot of people currently work, and there is union interest and there is dissent stroke comment stroke a active conversation for people who work in pathology. I think I've generally tried to describe that as there's a broad consensus that this is the right thing to do, but I do take your point, Councillor Burrow. I am quite prepared to come back and give you a much more detailed and reflective paper and presentation on that, and bring some clinical colleagues in to bring that conversation to life, if that would be helpful.
Yes, I think it probably will, but we'll agree on the way forward at the end of this item.
Okay, thank you.
Have Councillor Collins.
Thank you, Chair. So first of all, I just want to understand a bit more about the nuts and bolts of how it will work. So you partially answered this, I think, by saying places like Barrow might have more on-site facilities. But again, from a lay point of view, I'm thinking if you're getting a blood sample in Barrow and it has to go to Salisbury, you know, how does that work in an effective way? My second question is about with the hub and spoke model, where different types of tests are happening in different areas, is there a risk that the staff will be de-skilled by working in one or the other areas? And then the third one is about the IT system. So it's talked about the procurement of the LIMS system. How will that talk to the systems used by GPs, by hospitals? Will it talk to them, or will it be another system that they would log into to get the results? Thank you, Chair.
Okay, so if I can try and pick those up in the order you asked them, and if I don't answer your points because I've forgotten, please come back to me. So in terms of of how we're going to organise ourselves, and I use Barrow as a specific example of that, because you cannot transport some urgent pathology samples for more than a certain amount of time before they start to deteriorate. And I would make the point now that happens currently in our existing system. Our existing system, even with 4 large laboratories and some small laboratories, we do not hit quality standards for transport of samples to make sure they don't have to be repeated. So what we're going to do about it? So I think there are new ways of working. So, for example, the biggest problem is transporting blood samples. If a blood sample is not tested within 6 hours for things like urea electrolytes and full blood count, then they can start to deteriorate beyond the point of being useful. So we're looking at the use of drones. The picture I showed you will have a drone pad in it, and we've already looked at established drone paths in terms of how we transport samples of that very quickly. So that's the example of using new technology. I am talking to GPs about spinning samples off or preparing samples actually in GP surgeries, so that when they're transported, they are much more stable than they are now. And another thing that we don't currently do, which we should do, is transport samples in refrigerated vans, and that maintains the sample much more for a much longer period of time. So there's just 3 examples there of things that we don't currently do that we're actively looking to do in the future that will improve the quality of the sample when we receive it at the laboratory for testing. And it will, even though it might have been transported from further away, it will actually be better quality when we receive it. So these are quite technical things, and while the things I've described are not rocket science, there are other things that we can do that need a bit of investment or a change in the way we do things that will produce a much more effective testing environment. So that's one thing. You asked about our LIMS system. Well, currently we have 4 different LIMS systems. So LIMS stands for Laboratory Information Management System. It's basically the IT system where we enter all our results. There are 4 different systems across Lancashire, and one is just about to go off support by the current supplier. We plan to replace all of those with one central system that will connect to seamlessly to all the other laboratories. Now, I say that quite confidently because on a smaller scale, that's what we do now. The system at Royal Preston Hospital, which is the main lab, connects to the smaller laboratory at Chorley, the same scenario at Blackburn and Burnley, the same scenario at Lancaster and Morecambe Bay. So we have a lot of experience of central systems connecting to smaller or other laboratory sites. So one new system to replace all 4 with connectivity to all the smaller laboratory sites where urgent samples are doing. We're quite confident we can achieve that. We're confident we can achieve it within budget. We think we can actually achieve it within budget and save money. And that will be in place probably sometime within the next calendar year before we move to the hub and spoke to replace some of the current systems. So when we go live, remember that last slide I showed you, it will be live for months, if not longer than that, and will be available in the hub. And IT is not my biggest concern in my job as I come to work every day. The same applies to automation, and the automation, the results feed the IT system, and then we then supply those results to whoever. It can be a ward in a hospital, an A&E department, a theatre, or a GP practice. They currently receive GPs currently receive results through what's called an ICE system, which is a multi-dimensional interface. I won't go into the technology of it all, but is a very effective interfacing system. It's a third-party system. We know it will integrate with whatever new system we get, and GPs will continue to log into the ICE system to get results in their GP surgery, just as they currently do. So that, again, is not something I'm particularly concerned about. That's tried and trusted technology, and anything that we introduce along those lines will improve results for patients. It'll improve quality, it'll improve throughput, improve efficiency. Last of all, I think you asked about workforce. Now, part of the reason we're doing some of these changes is to better utilise our workforce. I am quite sure that by 2023, we will not have a huge influx of qualified scientists, qualified doctors, and people who want to work in the laboratory at a more support grade. We struggle to recruit. Everybody in the country struggles to recruit. But I do think by bringing our staff together, and we've done modelling around this, I expect some staff not want to move, want to retire, want to do different roles. That's fine. We built into our modelling, our prediction, retraining of people and people doing different roles. I think this will enhance the future service. It will allow people to specialise. It will allow us to train people in a standardised way to do the testing in a way that does not mean that if you go to Blackpool and get a result, it might be slightly different than if you go to Blackburn or Preston, and that is currently the situation. So I see the workforce advantages of this model being significant. And if that does mean a bit more flexible working, I think that will be for the benefit of patients and the benefit of our service users, but it will not be done at the detriment of making sure that we have enough resource to provide our high quality routine testing and deliver our urgent and emergency testing as a priority. I think I've answered all your questions there, but please tell me if I haven't.
I think you have. I wasn't expecting drones. That came as quite a surprise, as did the fact that refrigeration doesn't seem to already happen. So in transport. So, but thank you for those answers. I think you have answered my questions.
Thank you.
Councillor Dowding.
Thank you, Chair, and thank you, Mark, for your presentation. Like somebody else has said, I'm a lay person and I don't know anything about blood or pathology, except I'll just start, and this is a surprise to me, that on the 31st of August, I received this text out of the blue from my GP. Due to the national shortage of blood bottles, please do not contact the surgery to make an appointment for bloods unless a GP has told you this is urgent. So there's clearly some other issues going on with the pathology service, and as basic as blood bottles availability at the moment. So we've just had a presentation this morning about the mental health services across Lancashire, which I think we all did know as a committee was in crisis, and they've received around 12 million. I think many of us here didn't know that there was a crisis in the pathology service, and you've received 2.5 times that amount, if I understood the figures right. So this is all quite new to us. One of the things I want to mention, which hasn't been mentioned at all, is have you looked at the carbon impact and the long-term future-proofing in terms of carbon emissions of the changes you're making? And I say that because everything that you've said so far seems to me to have significant carbon impact in terms of potentially increasing the journeys around the county to a centralised service rather than less centralised, and also the embedded carbon actually in a brand new build that's possibly less convenient for 800 staff, or is going to create more long-term staff journeys. So I do think that as an organisation, the NHS, that's made a commitment to looking at net zero, I'm not sure whether it was 2030 or 2035, these things must be integral to the decision making that's going on. We're also hearing about the transformation of hospitals. So there will be new, potentially, buildings coming online in areas of population that might not be used in the future. So it will be good to know that there's a little bit of joined up thinking, and the future proofing that I know you're very, very keen to solve isn't just looking at sort of like the traditional thinking, but also some of the other things that might come on that are important, which is carbon, but also things like more testing by patients themselves. I mean, who'd have thought that we'd have been doing our own COVID testing 18 months ago? So there's other things that maybe are going to be changing where we won't need a centralised service because the tests themselves will be able to be done easier in the community by patients or by GPs. So just to say, really, it seems to me as though there's so many different factors that we can't actually know what the long-term implications are going to be. So all these potential changes should be taken into consideration.
Thank you, Councillor Downing. I'd like to just raise a point of order, Chair, at this point. I am a councillor, a district councillor in one of my other roles, and to accuse the NHS of joined up thinking, I think is a step too far at this moment in time. That's humour, by the way, so I'll just leave that there. So you make several points, Councillor Dowding. If I can address your main one, I do want to come back to plastics as well because it's important. I can answer this one very thoroughly. So by 2023, we have committed to, and we are asked to anyway, produce a carbon neutral service. Currently, the service is hugely carbon not neutral. I don't know what the right terminology is. So an example of that is the building, the service has to be electric. We cannot have gas supply to heat the building or any other form of energy other than electricity. It will have to have solar panels on the roof. We are building in electric car charging points on the car park for staff as people increasingly move towards electric cars. All our vans and vehicles are planned to be electric. You're quite right, we will be driving about significantly throughout Lancashire, and even to the point of we're looking for suppliers who are actively thinking about using hydrogen as a fuel source for the larger lorries that will transport things about. We're actually taking on board and considering. We're thinking about how staff move about Lancashire. So, for example, we'll be encouraging staff to use rail and then putting on shuttle buses that will be electric shuttle buses. So we're putting a lot of time and effort into thinking about our carbon neutral status in the future and our responsibility to the world in terms of how we provide our service. I can't give you the same level of detail about the carbon impact of building a building, but I know there are quite significant rules and regulations about that as well. So I think just by that very brief answer, I want to give you reassurance that we're actively thinking about it and building it into our future plans. It does put the price of the building up, for example, by I think something like £2.5 million in terms of incorporating technology over and above the minimum requirements. But it's the right thing to do. We are probably the last generation of people who have the opportunity to prevent the global warming getting to a level where it's completely reversible, if that's not already the case, which is a scary situation. So I'll leave carbon neutrality. So the aim is to be at least carbon neutral. We are endeavouring to be more than carbon neutral. In fact, actually giving energy back or whatever that criteria is into the national grid. So that's my thing on carbon neutrality. A very important point. Your second point was around plastics. Now you're quite right. You would have got a text from your GP. So about 3 weeks ago, one of our major plastic suppliers of blood bottles, so the bottles you put blood into when you go and have your phlebotomy done, gave us notification that due to several factors, not least of which an international plastic shortage, the fallout of the blockage of the Panama Canal, believe it or not, Brexit, etc., we are experiencing a national plastic shortage. So the company is Becton Dickinson. Now, fortunately for Lancashire, that only supplies Lancaster. So the rest of Lancashire is okay in terms of resilience. But the government, the Department of Health and Social Security, issued a directive, bearing in mind they thought that this could spread quite quickly to all suppliers, that GPs should reduce all their blood taking to an absolute minimum, except for urgent samples, which is essentially the test you received, and hospitals should reduce their testing by a minimum of 25%. I have to report on that on a daily basis to the DHSC, about what we're doing and how we're doing, and I have to use proxy indicators of reductions in tests to demonstrate that Lancashire and South Cumbria is actually following the guidance. Now, that guidance runs until I think the 19th of September, when it will be re-evaluated. And that's a key date because Becton Dickinson, a major supplier, are supposed to open a new factory in Bournemouth on that date. And if all goes well, the situation will ameliorate very quickly. I think what it does demonstrate, Chair, is that the fragility of some of the supply side system, logistics in this country, are probably underestimated. We've seen in supermarkets, haven't we? Supply problems with certain foodstuffs. And I think this is another example. And without wanting to make this political in any way, I think we are seeing the outcome of a major change in society, leaving the EU, and a system that's trying to adapt to new ways of working and new supply chains. So both good points. I think hopefully I've demonstrated that I'm all over both of them, and we're very serious about the service we provide. And if Carver is an example of that, then I've gone through that, and also dealing with the current crises or situations we're encountering, such as plastic tubes. Thank you.
Finally, I've got the page on Teams. That's the page you want to put.
Thank you. Thank you. Thank you, Chair, and thank you, Mark, for your presentation too. My questions, some of them have been partly answered already from previous participants, but I really wanted to ask about the staffing. Particularly, there's a number of mentions of retraining, staff in emerging technologies, TUPE, etc. within this document. I'm just wondering, I believe that there is a current dispute with some staff, particularly at the Burnley site. I note that you're saying a TUPE consultation formally should begin in October. Will that affect that at all? And secondly, I'm wondering what is in place to prevent staff from sort of leaving the NHS. Obviously, everywhere in the NHS needs staff, and there is going to be scope to retrain, I'm assuming. But how will that be undertaken? Thank you.
Okay, so I'm getting a lot of very good and very incisive questions this morning. So thank you for that. So as best I can, yes, you're quite right. We will look to start TUPE consultations with all our staff in the next month or so, with a view to all the staff coming together with one new employer by the beginning of April next year. And that's critical to allow us to start reforming and transforming the current services. I'll come back to that in a bit about training. I just want to address the point you raised about the current dispute that's focusing on East Lancashire Hospital Trust. I think implicitly, what I've said is that I don't currently manage the existing pathology services until next April. So that dispute is one with the staff and East Lancashire Hospital, and it's about working practices that have been in place in the blood testing laboratories for many, many years. The staff took out a grievance against the trust, and the grievance was not upheld. And in the leadership with their union, which is a Unite, they balloted to go on strike, and they balloted again to go on strike, and the current ballot goes on for several months yet. So that is about a local issue and not about the pathology transformation issue I've talked about, but is impacting on the way we provide services in Lancashire. But it's also a good example of other parts of the system stepping forward and ensuring that they can do that work on behalf of East Lancashire patients, and East Lancashire GPs and patients are not seeing any detriment in service or results reporting. So while I'm not commenting in any way whatsoever about the validity of the grievance and the strike, I am really pleased to see how pathology across the rest of the county has risen to the challenge of ensuring that patients receive the results they need on time, of the right quality, and our GPs have expressed to me how satisfied they are with the results service that has been put in place. It is a strain, it is a struggle, but we are managing, and we're managing effectively. And hopefully the dispute will come to some resolution as quickly as possible, so that those staff can get back to work and start earning the proper salaries. But more importantly, the patients on East Lancs Hospital site and the patients in East Lancashire, of which I'm one of them, will continue to receive the service that they need and expect. In terms of your broader other question about retraining, I think in broad terms that this is a significant opportunity for lots of staff. This is not, I've got a board agreed no redundancy policy, so we are not looking to make anybody redundant out of this process. I do appreciate there may be individual circumstances where, for example, staff can't travel, but it will not be, there will be no forced redundancies. Staff will stay on NHS terms and conditions, and they've said that is massively important to all of them. And I understand that. I've worked in the NHS for 43 years, and those NHS terms and conditions are not just about my pension, it's about my passion to provide a good service to the NHS and for patients, and that's really important for people. So your broader point about retraining, there'll be lots of retraining opportunities. There'll be opportunities for people to specialise in things that on a certain site might be 1 or 2% of the daily work. When we bring it all together, it may be quite a significant department. So I'm thinking about things like molecular biology, genetics, all that kind of specialised stuff that people will then be able to do, specialise in, do further degrees, and will be able to develop, offer people development opportunities for their career. So I think that's a real positive. I don't really see a lot of what you might just colloquially call dumbing down. There will be new technology, new automation. That'll be exciting opportunities for people to learn new things. And one of the good things about coming together across such a large geographical footprint, from my perspective, is, and I don't want this to sound the wrong way, but there are not a lot of opportunities for people to leave and go to other places. So in terms of a workforce that will stay and work in Lancashire and South Cumbria, I think that's quite a positive thing while we go through this journey of change and transformation. Thank you.
Thank you, Mr. Hindle. That concludes our questions. So we're going to now consider the recommendations and the way forward. It's felt appropriate that I ask the members of the committee whether they feel that there's a substantial variation. It does make a difference. The criteria are changes in accessibility of services, impact of wider community and other services, patients affected, methods of service delivery, and potential level of public interest. My personal view is on balance, I don't think it is substantial variation in terms of patient service, so it shouldn't be from what we've heard. Are we in agreement with that? So that's a agree that it isn't. The recommendations in the report are to receive the update and note the timescales in it. That was Appendix B. We'll do that, yes. Seek assurance from, well, Mark Hindle is the chair, that his work will benefit the health economy. It will certainly attract investment in pathology services across Lancashire. So I think it's a very positive move. But any change, any centralisation presents difficulty. I think from what we've heard that they're going to be addressed in a satisfactory manner. We're all happy with that. Any comments?
Chair,
sorry.
Just picking up the point that Councillor Borrell made, very useful if we have an update from some of the comments and stakeholders, so we do know the process is going smoothly.
Oh, well, that's the next point of and the 3. It's receive further updates at agreed points and things. I was coming to that, but yes, I will agree on that. So we're agreed on 2 of the recommendations, and the 3 is to receive further updates at agreed points in time to gain assurance the programme of work remains on track. I'm just looking at the there's a timeline on that back there. I was thinking 12 months' time, an update on progress. You look at the various, which would bring us to sort of September or autumn, hopefully building starting. If there are issues, we'll probably hear about it, about agreement. But can I just ask you, Mark, if the trust didn't agree, would it be imposed? Can it be imposed? I'm reading around that there are quite a lot of hubs already, and there is, and your paperwork indicates there are going to be 29 nationally eventually.
That's right. It's a difficult question to answer, Chair. I think so. We've had the policy; it's national policy. So the trusts have been told through the Department of Health and Social Security, this is national policy, and you shall implement it. There is a flexibility to some extent in how you implement the policy, and we've chosen to do it this way in Lancashire and South Cumbria. As anybody, the situation then by default has never arisen. All the trust boards have signed up to the outline business case and the strategic outline case, and even informally through the conversations I and colleagues have with them on a regular basis, they are supportive of this change. I think when you look at that in the context, Chair, of Lancashire NHS being very significantly financially challenged, there are very few programmes that are coming forward to both improve quality, improve effectiveness, and save money at the same time. So this is like a golden nugget of those three things being combined. So why would any of the organisations, what the board said to me, why would we not support you and not support this transformation? You both improve quality and you do it for less money. And also then implicitly that if they need to put their hands in the pocket, or the ICS integrated care system do, for example, of things like digital technology, then they've indicated in principle that they'll be supportive of that. So that's a long answer to a short question, but it's not straightforward.
I always ask short questions. Thank you for that. So were you happy for an update report to come back to us 12 months' time? Perhaps go through the steering committee first, see what it reveals. If it's all going ahead, then it might be worth waiting for something later until it's actually in place before it comes back. I'm sure we'd like to keep an eye on how it's progressing. So thank you, Mark. Councillor Hindle. I knew you were. I wasn't going to mention it, although I did have a slip at the beginning. Thank you for the presentation.
You're very welcome. Thank you for your time and letting me speak to you.
With the what you're doing. Thank you.
Thank you. I'll leave now.
Right, cheerio.
Bye.
Right. That's item 6 out of the way. Item 7 is a report of the Health Scrutiny Steering Group. We had a lot to look at trying to work out the work programme. 2 meetings. I thought it was very positive. Good cross-party working. I didn't intend to go through it. What does my notes say? Is there anything I need to bring out on that? It is just for noting anyway. So, is there any questions? Councillor Downing.
Just to say, Chair, I was on the steering group for a short period of time a number of years back, and I do realise it actually is a big commitment and lots of work for the members on the steering group. So well done to everybody who has been doing that work, and I'm very happy with that report and the proposals for the work of the Scrutiny Committee over the next months as a result.
Thank you. It's a lot more work for Gary Halsall, I think.
Chair.
It is. Yes.
Knowing Councillor Burrow, knowing that he was leaving, did raise with me briefly when looking at the GP workforce item. He wondered whether it would be possible to expand it to include
Dentists.
Looking at appointments as a whole, and some concerns that were raised with him about access to appointments and access to face-to-face appointments. I don't know whether that's something for the steering group to take away and have a talk about, but I didn't want to leave that unsaid as Councillor Burrow had raised it with me.
Well, we have another meeting in the steering group next week, is it?
Next week. Yeah.
We'll chat about it then, is that? Yeah.
Thanks, Chair.
Anything else? No. So, yeah, Councillor Downing.
Sorry, one other the thing specific issue I wanted to mention was the new hospitals programme, which I know is earmarked to come at some stage back to this committee. I think when you see fit. But I gather that there is now a shortlist that's just been published of the options. So, I mean, it's almost something that this, certainly for those of us in Preston and North Lancashire are very, very keen to have to keep an eye on. So it's just to say, how will you decide when to bring that back to committee? Because I think there could almost be an item every meeting on a 3-monthly basis.
I mean, it is a big issue. Likely to be bound to be a controversial issue somewhere. Is when we can make it's worthwhile actually when we can make a difference. At the moment it's progressing, isn't it? Various papers have been issued.
Chair, may I come in on that particular item? On the new hospitals programme, Councillor Downing is correct that a long list of options has been put out, and also a survey for people's feelings on that. The new hospitals programme are coming to the next steering group. So I think that is an opportunity. And I'm certainly happy to take informal soundings from members in those areas. I have mentioned to some of the Preston councillors that that's happening, because, as the chair said, it's a very big and very controversial issue. But I would hope that we would have something to come out of the next steering group with. What do you think, Chair?
I suspect it'll be coming to every steering group in one way or another. I'm really looking forward to having it on the agenda. Fine, so we noted that report. Yes.
You did allude there to access to dentists, and it is something certainly residents have contacted me about. Living in Penwitham, and the nearest available dentist is in Liverpool. Now, is this something that you will be looking at?
It's something I wanted to raise at the steering group. Practicalities. We raise them, and then Gary has to do the research and come back and tell us whether we can or not. So, but yes, I know locally it is an issue. I presume it is everywhere. And then we have item 8, which is the work programme. We're asked to discuss and agree it, and receive any additional representations. Are we had some comments on that? Does anybody want to make a comment on it, or are we happy to accept it? Agree it? I'll take that we're agreed. Yeah. Item 9, urgent business. I have none. And the date of the next meeting is Tuesday, the 2nd of November, 10:30 here. I think we'll probably have the pre-meeting as well, because I thought it was effective today. So that's the date of the full formal meeting, but we'll meet again at 10 o'clock on that day. Can I thank you all? I appreciate it. I was wary, my first one of these, so I thought it was a very interesting meeting.
Thank you, Chair. Very effectively chaired. Thanks.
Gang.